Official, Chennai's winter has begun. Okay, so it's going to get colder and more rains. So welcome to all of you. Just a small request, could some of you come forward if that's okay? Could you move up, please? Those at the back. Come. In the meantime, I would like to invite our special guests. So may I invite Dr. Kalyani Kenneth to come on the stage. Yes, thank you, ma'am. Thank you for coming. And Professor Raja Samuel, please come on, because you're integral part of the MSSW institution. And of course, Dr. Mahesh Menon, who's been very generous with his time. He's on vacation, and this is our little gift during your vacation to all of us, from all of us at Banyan. Please, come. Thank you, Mahesh. Could you ask him to settle in? Come. Can you move up? Come. Who? Ramesh? Yes. So as you can see, today's topic is very interesting. It's about functional improvement in psychosis. All of you who are here from social work, applied psychology backgrounds, welcome to all of you. And this is a very interesting topic. It's trying to understand the different multimodal approaches in psychosis. As we all know, a very difficult, part of mental health issues. And we're really excited to hear Dr. Mahesh's insights. And he's come down from Vancouver, and he's going to share his experiences working in clinical settings and also doing therapeutic work. So thank you so much, Dr. Mahesh, for, we're really looking forward, because we do know that Canada has a lot of multicultural elements, and how do you then flexibly adapt and so on. We have a lot of lessons to learn. So I'm going to invite Dr. Ramesh to give a small token of appreciation to our guests seated on the stage. Yes. And these are beautiful gifts made by our vocational training center, by our very own clients. And to, yes, we'll take it. Yes. Yes. And Professor Kalyani, thank you, Ramesh, for giving. So I'm going to invite Professor Kalyani to introduce the keynote speaker today. So over to you, ma'am. Thank you.
Thank you, ma'am. A very good afternoon to this august gathering. I take this opportunity to introduce the speaker of the day. Dr. Mahesh Menon completed his PhD in psychology at the University of Cambridge, UK. He is a clinical associate professor and head of the schizophrenia program in the Department of Psychiatry at the University of British Columbia in Vancouver, Canada. His research and clinical interests are focused around understanding the symptoms of psychosis, particularly delusions, and in psychosocial interventions for severe mental illness. He has published over 75 peer-reviewed papers and book chapters. Today's lecture is provided in collaboration with the Department of Psychology at the Madras School of Social Work, which aims to explore the different schools, dimensions of psychosis and the therapeutic interventions that address them. Furthermore, the session will address the efficacy of cognitive behavior therapy in treating psychosis, particularly in managing delusions and enhancing social functioning. This lecture is for students and individuals working with or caring for persons with mental illnesses. I welcome you all, and the floor is open for the lecture. Thank you.
Hi everyone, thanks for coming out. So it's really nice being back here and giving this talk. It's also full circle because I started my introduction to psychology was by working with Dr. Bandana at the Banyan in 1995. Yeah. So I guess that makes me feel like an old man officially as well. So I became very interested through volunteering at the Banyan 30 years ago around what were delusions, because to me, as a young 18-year-old, I could understand depression and anxiety, but I didn't really understand how do we develop delusions and what does it mean to have that. And that was the question that I became really interested in, and then thinking about how do we develop treatments for delusions sort of progressed out of that work. And so what I wanted to do today was to talk a little bit about what are different levels of understanding of the illness itself, and how can we kind of think about different treatment approaches that we can use to work together. So, I'm going to talk, I recognize that some of you will be very familiar with some of it, and hopefully all of you will have some bits of the lecture that you are not familiar with and that you will learn some from. So I'll talk very briefly about what is schizophrenia and our kind of historic overview, and then talk about the biological model of psychosis, some psychological perspectives around it, as well as the social factors which are associated with psychosis. Now, because schizophrenia is a broad term, I'm going to use the term psychosis and schizophrenia interchangeably. And then we'll talk a little bit about different types of psychological interventions for psychosis, and what does that mean for the sort of big picture of recovery. So what is schizophrenia? We can think about schizophrenia as a persistent, severe mental illness which is characterized by different types of symptoms. So one of the terms we use for delusions and hallucinations are positive symptoms, not because they are positive in the sense of good, but because it means that there is more of something happening. And then on the other hand, we use the term negative symptoms for features like what are called amotivation or apathy, where it's that I'm doing less of something than I used to do before. So difficulties with motivation, difficulties with getting started with tasks, difficulties even with things like basic hygiene can sometimes happen and those are classed as the negative symptoms. Then there are what we call the disorganized symptoms. So this is sometimes the term that's used is thought form disorder, which is like difficulties with kind of how we communicate. So a person who's struggling with psychosis might not string sentences together. Their mind might jump from one thought to another, or even from one word to another. And those are the disorganized symptoms. In addition to it, we know that many people, not everyone, but many people who struggle with psychosis have some declines in different domains of cognition. So things like memory, attention, executive functioning, social cognition, and so on. And I'll talk a little bit more about that as well. And really importantly, these difficulties cause distress, and they are associated with declines in their everyday functioning. So hallucinations are essentially, we can think of them as false perceptions. So it can happen in any of our five senses. So it could be hearing, vision, touch, smell, taste. But the most common ones are auditory hallucinations. So this is where people hear voices. And there are different types of voices that people might struggle with. The most common types are where people hear voices which are commenting on what they're doing, or sometimes they're criticizing them. And sometimes There may be more than one voice, and they may be talking to each other, almost always about the person itself. And sometimes people have what are called command hallucinations, which is where the voice demands that they do something, usually something that they don't want to do. So people never hear command hallucinations that say, brush your teeth, clean your room, but more commonly it might be hurt someone that you love, or do something that you don't really want to do. So those are very distressing to the person. Oh. Oops, yes. Thanks. And the other common type of what we call the positive experiences are delusions. And delusions are really kind of, when we think about psychosis, we think about delusions, and pejoratively as well. The Jaspers, who was one of the people who talked a lot about it, he said, like, since time immemorial, that was taken as the basic characteristic, right? And so now when we are thinking about it, even when I went into this work about 30 years ago, we used to think about it as something that we couldn't really understand. We wouldn't really know why people have the beliefs that they do. But I think in the time since, we've really come to understand that we can see these beliefs as coming out from people's life experiences. But the belief itself is the DSM sort of describes it as a fixed false belief about the world around, which the person holds on to despite there being evidence to the contrary. And the belief is not held by other people in the culture, or it would be considered extremely unlikely. So there are different types of delusions. The most common one is delusions of persecution or paranoia. This is where someone believes that other people are following them, watching them, and trying to harm them. The harm can be physical harm, or the harm can be social harm. Like, people may believe that other people are gossiping about them, spreading bad things about them. The other most common experience are what are called delusions of reference. And this is where people believe that stuff which is happening in the world outside refers to them. So, for instance, you are watching something on TV and you think, the person on the TV is talking about me. That would be an example of a delusion of reference. There may also be what are called delusions of grandeur, which are where the person believes they have some special powers or abilities, or they are, someone rich or famous. We can also have delusions of control, where the person may feel like they're not in control of their body or their thoughts, and it feels like other people are controlling their movements or their experiences. And then there are other atypical ones, or actually in some places, and in India, one of them, delusions of jealousy, where the person believes that their wife is having an affair with someone else. Those are actually quite common as well. And there can be versions of different of these experiences which are happening side by side. So people have a belief, but it is not just a fixed belief. It can sometimes be multiple things which are kind of woven together into a belief system itself. So how do we understand it, right? And really, my hope for you is, as we start to see these experiences through different lenses, we're going to kind of move away from this idea of like just madness in some sort of like pejorative, ununderstandable term, to something that we can see as happening for a variety of reasons, some biological, some psychosocial, and hopefully allow us to have a greater understanding, and through that a greater compassion for the people who might be struggling with these difficulties as well, right? Because through history, the people who've had these difficulties have faced so much stigma and misunderstanding and hatred, and even from people who, were the greatest thinkers of their time. So for instance, Plato was regarded as one of the greatest philosophers, thought that all psychopathology was due to a lack of intelligence, which we know is not the case, right? There are people with schizophrenia who've won Nobel Prizes and are great authors and artists and visionaries in all different fields. When later on people believed that there was a sort of like what they call the humors, so blood and phlegm and stuff, and they thought that illnesses were due to an imbalance of the humors, and that delusions and hallucinations were due to an excess of blood of one of the four humors. And these were all what were called like the somatogenic theories. They're like kind of theories that say that there's something happening in the body which is causing it. But then, of course, in the Middle Ages and in other places, so in India, for instance, the big ideas were that this was due to like a curse or possession by demons and punishment for sins and so forth. And these were kind of the non-body related ones, the feeling like it's coming from somewhere outside. But, oops. But, gradually there started to be kind of, from about the 1700s, the development of the idea that this can be a mental illness understood like other illnesses itself. In the 1700s, they were starting to separate out psychiatry from theology. So thinking about an explanation for it which had nothing to do with possession, for instance. And then in the late 19th century and the early 20th century, these terms, dementia praecox and schizophrenia, came along. So the term schizophrenia, I think there's been so much misunderstanding as a result because people thought of it as multiple personality disorder, but it's not that. It's really like Bleuler, who used... Oh yeah. The person who coined the term, he was a German psychiatrist named Bleuler, and he used the term to mean a shattering of the self itself. And there were different types that they had classified, which were called like the catatonic subtype, the hebephrenic subtype, the paranoid subtype. But these ideas were very, very influential in the development of the initial kind of textbooks of psychiatry. So in North America, where I work, the manual of psychiatry is called the DSM, or the Diagnostic and Statistical Manual. And for many years, the first 4 editions had these subtypes of schizophrenia, and this time, for the first time, they've removed those. But now the way that we think about it is we don't think that it has anything to do with, spirits in possession, but we do think that it has to do with a combination of factors where we think of it as a stress vulnerability model. So we might each have a varying level of vulnerability to developing an illness. So there is no one gene that causes schizophrenia, but rather, it's a combination of multiple, hundreds of genes potentially interacting with one another to cause the illness. And we think that we are born with some level of genetic vulnerability to it. But if we deal with a lot of environmental stressors, particularly things like bullying and trauma that can increase our risk for developing it, there might be other factors like substance use, particularly stimulants like cocaine, amphetamine, meth, and cannabis, which can further increase the risk. And the combination of factors together can lead to the development of it. So one person might have a high vulnerability, lead a very stable, happy life, but still develop the illness. Someone else might have a low genetic vulnerability, but they struggle with a lot of bullying and trauma, and they cope with it in an unhelpful way, but they might kind of go on to develop it as well. So we don't fully understand, but there are these different pathways to developing the illness. So we can really then start to understand these difficulties as happening at different levels, right? There are kind of the genetic neurodevelopmental processes, which in turn can lead to some difficulties in the brain, and neuroanatomy and neurochemistry. There might be some changes that happen at the psychological level of understanding, and as a result, there may also be social impairments that the person's struggling with, and they may also deal with more environmental stressors, as well as be more impacted by stress than someone else might also. So that combination of factors can lead to developing the illness. And that's what we think of as the biopsychosocial model. So I'll talk very, very briefly about it, just so that you have a sense of like what might be the sort of causes or maintenance factors at each of those levels. So the first part we'll talk about is the biological part. So when we're thinking about schizophrenia from the lens of like biology and neurobiology, how do we understand it here? And I'm particularly going to talk about one model or hypothesis around it that we call the aberrant salience hypothesis of schizophrenia. So, even up till the 1950s, there weren't medications that were available for psychosis itself. And one of the treatments that they did was to induce what was called an insulin coma. So they would give people a high dose of insulin, and the person would go into a coma, and when they came out of it, they thought they seemed calmer, and they thought that might be a treatment. And so, interestingly, one of the medications that was used for the coma to prevent them from throwing up, and was a sedative, was chlorpromazine, and it was found to have an effect on delusions and hallucinations beyond of just the sedating effects, and that was really the birth of the idea of the antipsychotic medication. And the idea that these medications acted on some specific neuroreceptor in the brain, in this case the dopamine receptor, actually was the work that led to a Nobel Prize for Arvid Carlsson. So what is dopamine? Dopamine is a neurotransmitter, sometimes called a neuromodulator. It's produced by nuclei in the midbrain. There's that little orange blob in the picture, and there are a number of different pathways. So it's produced there and then transported out to different parts of the brain. And so we will. Within psychosis, one of the pathways that we're interested in is one that goes from that orange spot to the bit that's called the caudate nucleus there. Essentially, what happens in the brain, and this is the sort of basis of all different kind of brain activity and brain transmission. So we've got neurons, and neurons connect to other neurons, and then how they actually communicate with each other is that in the gap between the neurons, that gap is called the synapse. And in there, basically the electrical signal that comes through one neuron causes those brain transmitters to release into the synapse, where they then kind of signal the neuron on the other side of that gap. And so it's thought that the signaling between those is kind of what might be driving some of the differences in brain activity and brain signaling and so forth. So we think that some of the problems, if you will, that are happening in schizophrenia are happening because of problems with dopamine signaling in the brain. And there is a bunch of evidence in favor of this, like for instance, drugs like amphetamine actually increase psychotic symptoms or can cause relapses in people who are vulnerable to it. And there's a whole body of research on differences in dopamine synthesis, dopamine release, and synaptic dopamine, which is super nerdy and I'm not going to get into here, but you'll just have to take my word for it. And so we think probably, yes, there are issues with dopamine signaling and dopaminergic abnormalities. Now, interestingly, when we look at what does antipsychotic medication do in the brain, this is some data from my former boss's lab. His name is Kshitish Kapoor. And essentially, that bright picture you can see on the left is using an imaging method called PET. And what you can see is that the PET radio tracer binds to the same dopamine receptors, and so that the bright colors suggest that there is a lot of dopamine availability in that part of the brain. And then when you've given them the antipsychotic medication, you can see that there is less receptor binding that's happening there. So if you think about if you think about the way the neurotransmitter binds to the receptor, we can think of it a little bit like a lock and a key. So there's the receptor and the dopamine goes and it binds to it, and when it binds to it, it triggers the postsynaptic signal. So it's like that's sort of like the transmission of the signal, if you will. And the medication binds to the same site that the dopamine would bind to, and it sort of turns down the volume of that postsynaptic signal. That's the sort of oversimplified explanation for what might be happening. So we know that the dopamine that binds to those receptors drives the antipsychotic activity, and there's even been studies that actually have shown that you need a certain amount of those receptors to be blocked off for the binding to happen to start to see the antipsychotic effect itself. So that now allows us to do better dosing for medication. So this methodology is now used for when there is a new drug that's being developed. It helps to understand what would be the dose of the medication as well. But, you know, when we're thinking about it, it's really like a big question that's baffling to many of us is, well, why would blocking a dopamine receptor help to change a person's belief? It seems like such a kind of far reach. And so it's helpful to just think a little bit about what dopamine does. Dopamine does a bunch of different things in the brain. You know, it's involved with movement, and one of those dopamine pathways that goes from the midbrain nuclei that I pointed to the putamen is involved with Parkinson's disease. There's a different dopaminergic pathway which goes from there over to the frontal lobes, and it's involved with paying attention and decision making and so on. And there is one pathway which is involved with reward and punishment, and that's the sort of pathway that we're mostly interested in here. So some very interesting research a while back where they looked at kind of how do animals and the same humans learn, looked at the firing of these dopamine neurons. And so this is an animal study. So the monkey is given a juice or fruit reward whenever a light goes on, and they can track the sort of firing of those neurons. And what they find is that initially those neurons fire when the monkey, in this case, gets the juice. But then as the monkey learns that the light means I'm going to get juice, then those neurons fire when the light comes on, and not necessarily when the juice is given to them. And then if the light comes on and they don't get the juice, then there's kind of a change in the firing pattern. So that's really how, in this case, the monkey, but also all of us, are learning these associations. Like we have positive associations with some things and negative associations with some things. So those neurons seem to encode what we call the prediction error of rewarding outcomes. And a bunch of my early work doing neuroimaging had been kind of focused around trying to understand, you know, are there different clusters of neurons that focus on reward and punishment, and our lab was really interested in this. But we know that those neurons fire not just in response to reward, but also to negative stimuli, which may be potentially involved with a negative outcome. So like, you know, if a light flashes and you're going to get a shock, then when that light comes, it triggers the anxiety because we're learning that that light means something bad, right? And they seem like there are different clusters of neurons which fire in response to those positive outcomes or negative outcomes. And so we think that basically the firing of those neurons is saying, this is important, pay attention to it because it could be good or it could be bad. And so we can think that the dopamine sort of mediating what we call the attribution of salience to external events. And those neurons in turn are connected to like the parts of our brain which are like the frontal lobes, which are involved with then, you know, making the plan to how do I avoid the bad thing happening, or how do I kind of go and get the rewarding thing, right? And it's also connected very much to what we call our limbic system, so the parts of our brain that process emotion. So when people are developing delusions, they would say things like, I noticed things that I hadn't noticed before, or little things were seeming very significant, or it felt like something really big was about to happen, or I was trying to solve a puzzle. And these are dated references, but you know, people often said, I felt like I was in the Matrix. You know, something is happening in the world and it doesn't feel right, and I need to figure out what's going on. And sometimes people said, like, I feel like I'm in a show and people around me know something about me and they're watching me for some reason. So, you know, what we think is happening is that when people are developing psychosis, those dopamine neurons are firing, and they're firing at maybe random points, or they're firing in response to some other types of stimuli, but it's making the person feel like something really meaningful is happening in the world around them. And in this explanatory framework, the story they come up with for why something feels really important or meaningful becomes the delusion itself. And there's obviously a lot of psychological factors which are involved with the type of story that the person might go to, but it'll also be based on their life histories, right? So someone who, so let's say, for instance, the person has a sense that whenever someone is walking past, they think that, oh wait, that person knows something about me, or they're looking at me and they're following me. Someone might think, that's like the secret police or the CIA that's trying to follow them. Someone else might think that, this is a satanic cult or something like that, just based on their own life experiences, their own interests and so on, and then they develop the belief kind of out of that. And so we can think that this is a really kind of simplified model at the very biological level, that the way the brain develops kind of makes us vulnerable to having that excessive dopamine reactivity. And as that is happening, that leads to the feeling of something weird happening around them. The delusion is the explanation for that feeling of weirdness. And then what the medication's doing is it's binding to those dopamine neurons and it's turning down the volume on it so the person isn't experiencing that as much. And then over time, the intensity of that belief kind of reduces. So interestingly, when you talk to someone who may have, say, paranoia, the person was very convinced that their neighbor was trying to kill them. They start to take the medication. And if you ask them, do you still think that they're trying to kill you? They say, yes, but I just don't worry about it as much. Like, it's not in the front of my mind, it's kind of like gone to the back of my mind. And when they have a relapse, the same beliefs often come right back up. So obviously, it's not that it's necessarily disappearing, but it kind of disappears into the background a little bit, if you will. So that, I think, is a reason why medications are effective, why most medications bind to those dopamine receptors. But obviously, that's not the whole story of what's going on. There's lots of other things which are happening in the brain itself. So kind of at the psychological level, we know that there are a lot of what we call cognitive biases which have been shown to be specifically associated with delusions themselves. And so when we think about how do cognitive biases, again, lead to delusions, we can think about the questions of, like, when we are first kind of making a decision or developing a belief, how do we kind of develop that belief? How do we choose between different explanatory frameworks, and why don't we change our mind when we're given new evidence? Because these are all factors that we think about in the context of delusions. So let's think about that first one. So we can't really think about it in the real world naturalistic sense of, like, asking people, how do you develop a belief? So what we're thinking about here is a very simplified part of that question, which is, how much information are you using to make a decision in a condition of uncertainty? So this was a task that I used for my PhD, and it's a really simple task where the person is shown jars which have beads in them, and the beads are of two different colors. And so let's say the jar on the left has 80 white beads and 20 black beads, and the jar on the right has 80 black beads and 20 white beads. And the jars are put behind a screen, and then we show them a bead one at a time and say, well, tell me when you're sure which jar you think the beads are coming out of. So what that allows us to do is it allows us to quantify the amount of information the person is using to make a decision. So it's one aspect of the decision-making process. And what we found was that people who have delusions use less information to make a decision than people who don't have delusions. And so about 40% of the people who have delusions, after they see the first one, they'll say, yeah, I know which jar it's from, right? And that means, so we call this a jumping to conclusions bias. And what that means is that in the real world, as soon as they see something which fits with their explanation, they might say, yeah, I think that's what's going on, right? I saw one guy looking at me, I think people are following me. So we think of that as kind of a risk factor to developing delusions itself. I'll skip over this, it's sort of getting at the same. And one of the studies that we did way back then actually suggested that this tendency to jump to conclusions, actually the people who showed that bias actually had a poorer initial response to treatment in the first 2 weeks of treatment than people who didn't show that bias. So the second question that we can think about is, how do we choose between different explanations or beliefs, right? And so we did a study, again, very similar, where in this case, you're told, similar to like the jars with beads, there's fish in a lake, and you're told like, okay, this fish came out, there's two conditions. In one condition, you're asked, which lake do you think this fish came out of, and how sure are you of it? And so the person can make their judgment, and they can make a confidence rating. So the person says, I think it came out of that lake, and I'm about 80% sure, etc. And then other times, they are asked, they're told, the computer thinks it came out of this lake, how sure are you? So what we find is everyone says when they choose the explanation, they actually have a higher confidence rating in their explanation versus when the computer chooses the explanation for them, which is kind of a bias that we all have, but that bias is even more pronounced in people who have delusions at the moment. So meaning that self-generated explanation carries a lot more weight than an explanation that is coming from someone else, right? So, of course, we all do that. If I have an idea and you have the same idea, I think it was still better when it came from me, right? But that bias is maybe even more pronounced. So we call that the sort of like self-generated explanation bias, and so we think that that could be why their own internal explanations may carry a lot more weight. And the third one is, why don't we change our mind in the face of new evidence? Now, for all of us, the stronger our belief, the less likely we are to change it, right? Think about your beliefs in your political systems, your belief in sports teams, your belief in religion, your belief in what flavor of ice cream is the best. Like, everyone has strong beliefs, and they will not change their mind if someone says objectively, here's a different explanation. But we can also look at just new beliefs itself. So we developed a study where we actually told people, you're going to see a story, and I'm going to tell you the story backwards, and I want you to tell me which of these explanations you think is true. And you rate each explanation separate from the other ones. So when you look at this, what do you think is going on? So most people might say, you know what, it looks like the man just built a fence for his dog, or he's playing with his neighbor's dog, because that's what looks like it's happening right there. Then you say, okay, so you rate each of those for how confident you are in that explanation. Then you see what was happening just before that, and then you update your ratings, and then you see what was happening just before that, and you update your ratings. So now you can see that what seemed likely, oh, that man's playing with his neighbor's dog, was not the case, that actually the man just escaped from the barking dog. So the first explanation, that fourth one, those are what we call lures. Those seem true, but then you get new information and they become false. And so you have to change your confidence rating in those explanations. Now, the nice thing with these stories is this is not connected to a deep belief that the person has held, right? This is just a new story, but it allows us to look at how much are people increasing their confidence when they get information that fits with their explanation, and how much are they decreasing their confidence when they get disconfirmatory evidence. And so, again, we find that people with delusions don't downgrade their ratings as much as even people with schizophrenia who don't have delusions, or people with bipolar disorder or healthy controls. So we call this a bias against disconfirmatory evidence, or BAID. And we think about this as a very key maintenance factor in delusions itself, because when they get information that doesn't fit with their belief, they're not able to integrate that correctly, right? So the person thinks there are cameras spying on me from the walls. They may go look in the walls and look in the ceiling and they don't find the cameras, but they think, well, maybe the cameras are just hidden and I'm not able to see it. They're not able to take in that disconfirmatory evidence itself. So helping people see that could definitely be one way that we can, again, kind of help them change or, reduce their confidence in their delusions. There are lots of other cognitive biases, around attributional style, around the over-anticipation of threat, and we know that many of these thinking styles are impacted by factors like attachment and trauma, and so needing ways to address those is obviously going to be an important part of the treatment. And the trauma part also becomes really crucial when we think about the social and environmental factors which are shown to be associated with psychosis. So, there was some. This was a big finding when it had come out, but in the UK, where they found that psychosis rates were much higher in the Caribbean immigrant population that lived in the UK, even compared to their relatives who lived in the Caribbean. And interestingly, when they do some more nuanced analysis around it, so this was some great work from Dutch colleagues, they actually found that the incidence of psychosis was related to what they call ethnic density. So essentially where people feel like they're a visible minority and they're facing overt racism, the stress of that and the feeling, as they have experienced, that other people will harm me because they think I'm different from them, leads them to developing paranoia, which is kind of an understandable reaction in that case because other people are reacting negatively when they see them. We also know that factors like urban living, where people are less socially connected to each other, is a risk factor for developing psychosis. And when people have fewer social supports with each other, it's a risk factor for developing psychosis. When people have been bullied in school, there is a risk factor for developing psychosis because, again, you have the sense that there are powerful groups of people who will hurt me if they're given the chance, which is basically what a sort of, in quotes, paranoid delusion is. The only difference is there was a time in their life where that was absolutely true, but it's developing and showing up in a time in their lives as an adult when it may no longer be true itself, right? And when people are coming from marginalized populations, for instance, refugees, they have higher risks of psychosis. And very importantly, there's a huge comorbidity between PTSD, or post-traumatic stress disorder, in psychosis populations. And those numbers, different studies have varied from 36% all the way up to 90%, right? So trauma can obviously have a huge impact on the brain. It has direct impacts on the brain systems. So like what I was showing you, with those, like the amount of our brain which is responding to those positive and rewarding or threat stimuli, we know that people who have dealt with stress have much more of their brain looking out for negative or threatening stimuli relative to positive or rewarding stimuli, right? So it's impacting our brain systems, particularly those around threat processing and anxiety. And there are, of course, indirect impacts that it has on the brain itself. Dealing with trauma makes us feel terrible about ourselves. It leads to really poor self-esteem. We have very negative beliefs about how other people will respond to us, and it also increases substance use risk. So when we look at voice hearing, we used to think about voice hearing as a really bad sign. It's a sign that meant that you had psychosis itself. But interestingly, when we ask people, do you hear voices? And there were community studies which have been done. And what we find is, depending on how we ask the question, loads of people may have had that experience. So I'm not going to ask in this room, just in case people feel shy about it, but have you ever had the experience where you thought someone called your name and you turned and looked and no one had, right? or you were in a quiet room and you thought you heard someone call your name and there's no one around, right? So that experience, between 70 and 90% of the population will say, oh yeah, I've had that happen at least once. Now that is technically you hearing a voice. It is a voice that's calling your name, or it's hearing a voice saying a word. It's very common. It turns out that, you know, different surveys have found that between 6 and 13, 14% of the population say they hear voices with some regularity. Now let's even take a low-end estimate and say it's 6% of the population. And between 0.5 and 1% of the population who have a schizophrenia spectrum diagnosis have auditory hallucinations. What that means is that for every one person who's seen in the hospital with voices, there are between 6 and 10 people living in the community who have very similar experiences who are not seen in the hospital. So it's really important that it's not the presence or the absence of voices which dictates psychosis, but the distress that those voices cause, right? So the people who are seen in a medical setting are distressed by those voices. The voices are negative and have a negative impact on their functioning. Many community voice hearers have a more benign relationship with their voices, or they may have a better insight at their voices. But one hypothesis that we have linking these two things together is that if you were prone to hearing voices just because of how your brain is wired and you didn't deal with the same trauma, the voices are just not as negative, right? And so when we look at the people who are seen in a hospital, the sort of clinical hallucinations, those voices tend to have a more negative content, a more dominant tone, and are perceived as coming from the outside, and that person has no control over those experiences. So we actually know that voice hearers who are more likely to have experienced more negative traumatic events than the general population, particularly sexual abuse and bullying. And my colleague Amy Hardy, who's at King's, did a really fascinating study examining the relationship between trauma and the content of people's hallucinations. And she found that about an eighth of all the hallucinations had similar themes and content to their trauma itself. So we can really think about that almost as a direct kind of traumatic flashback. And almost half the voices, the hallucinations had themes which were the same, but it just kind of shows up in a different way, right? So let's say I have been bullied as a child and people kind of teased me about my appearance or said that, you know, I was ugly and they didn't like me. In my adult life, it might still be themes around my appearance or not being liked by people and being judged around the things that I'm doing, even if the words that are being said is not the same, the underlying theme and message is kind of exactly the same, right? And that's really important. And, you know, some voices, they don't directly connect to it, but it's really important to think that, you know, the same way that we can see that now the beliefs that people are developing can come from their life experiences, and the voices that people are hearing which are distressing to them can also be related to people's life experiences, right? So this is my hope, that we're starting to see that it's not a black box. It's not that we can't understand this, but we can understand many of these in the context of people's life experiences. So, you know, we can think about these different pathways to symptoms. Again, you know, we were looking at a sort of model at that biological level. We can similarly think of the model at the sort of psychosocial level, where childhood abuse or trauma can lead to developing auditory hallucinations, bullying and marginalization and poor attachment can lead to developing paranoia and persecutory beliefs. And all of these then kind of lead to the development of the illness, which has lots of other things which are happening with it as well. And, you know, so there are many things, and like, so those reasoning biases that we talked about, the emotional biases, all can kind of interconnect together at the psychosocial levels to developing the specifics of the persecutory belief that the person is experiencing. So, So when we are looking at psychosocial interventions for psychosis, you know, we are then targeting hopefully, those thinking biases and the trauma, as well as some of the sort of cognitive concerns which arise. So there are a lot of different cognitive interventions, or psychological interventions for psychosis. I am going to talk about these first three. CBT, a version or a variant of CBT that my colleagues and I have been involved with the development of, called metacognitive training for psychosis, and cognitive remediation, or CRT. So hopefully, and maybe a quick show of hands, how many of you have had any coursework or experience with CBT, or cognitive behavior therapy itself? Okay, smattering. So very, very briefly, CBT is a structured short-term therapy which is really focused on identifying cognitive or thought patterns and behavioral patterns, and the model assumes that these maladaptive patterns of thought and behavior serve to maintain different psychological disorders. So it's just a more broad way of thinking about how our thinking and our actions can lead to different types of psychological problems, including depression and anxiety and so on, as well as psychosis. So this is the sort of classic, what's called the CBT triangle. So the idea is, lots of times we say, something happened and it caused me to feel a certain way, right? But we're trying to recognize that it's not the situation that causes the emotion, but the meaning that we make of the situation that causes the emotion, right? All of those automatic thoughts that come up for me. And then when I have those thoughts, I act as if they're true, and those behaviors reinforce those thoughts and oftentimes reinforce that unhelpful emotion as well, right? And so we're trying to just kind of get people socialized to that idea of noticing what is the meaning that I'm making in any situation. So here's a common experience. You walk down the street, you see a friend, you wave at them, they don't wave back. You think, I think she's upset with me, I think I did something wrong. That thought, that explanation might make you feel anxious. You might call her, you might send her 10 messages, I'm so sorry, whatever I did, I'm really bad, and because we're acting from that emotion and as if that thought was true. If I thought, she doesn't like me anymore, you feel sad, maybe you just don't contact her. Maybe you withdraw from your friends. So you wouldn't send her that message that said, hey, I saw you on the street today, I was thinking of you, how are you doing? You don't do that because you think she doesn't really want to be my friend anyway, right? If you thought, wow, she's being really rude to me, maybe you send her a text message that says, oh, you think you're better than me? Well, beep beep, right? And that then can damage the friendship. So in all of these cases, the thought drives, the meaning that we make of that situation drives the emotion. But really importantly, we also want to recognize that it goes in both directions. The emotion that I'm experiencing might bias me to seeing the situation in a certain way. Let's say I was walking down the street and I was already, I'm hungry, I'm hangry, I'm irritable, I've had an argument with someone else before, I see my friend, wave at her, she doesn't wave back. My first thought is more likely to be, well, that's so rude, she's a horrible person, I don't like her, because I'm already angry. So that emotion acts as a lens through which I see the world, and it biases me towards having certain types of thoughts which reinforce that emotion, and that can be kind of being stuck in that emotion state, if you will. So it could also be a different explanation, like, oh, she was just lost in her thoughts, she was thinking about something she needed to do, she just didn't see me, and that's why she didn't respond. Maybe that isn't going to lead to a big emotional response. I can say hi to her the next time, the relationship and my sense of self are really unaffected, right? So what we're trying to do is to get people to recognize in CBT, in very, very basic terms, that, we constantly have thoughts that pop into our head. We call these our automatic thoughts. Sometimes we put those into words. Sometimes we can say it's the picture that pops into my head. Sometimes I might say, I feel as if they don't like me. That's not really a feeling, that's a thought, right? So we're getting people to recognize those. And we are targeting them by getting people to say, look, is that thought 100% true all of the time? Could there be any other explanations? Helping to understand how emotion biases us to seeing the world in certain ways. And then we also target the behaviors. Because if we act as if those thoughts are true, then it prevents us from changing those beliefs, right? So if I get a chance to actually challenge those thoughts by acting in a different way, that's a very powerful way to change my belief and hopefully my mood state as well. So really, that approach can be applied to CBT for psychosis also, because what we are trying to do is to reduce the distress and the disability that's being caused by the delusions and the hallucinations. We're hoping to improve their understanding of themselves and to, improve their mood and self-esteem, and really kind of see the client as an active participant in treatment, right? So in the sort of CBT for psychosis, we're trying to get people to challenge what the voices are saying and getting them to say, like, is that 100% true, right? Or if you think people are trying to harm you, is that 100% true? But what can be very helpful is in the process of therapy, a lot of it boils down to kind of what we call the formulation. And the formulation is, how do we understand the person's life experiences and how do those dots all kind of connect together, and that will dictate the kinds of interventions that we engage in as well. So this is an example of what we call the longitudinal formulation, where we say the early life experiences that the person had impacts their beliefs about themselves and about the world, and something may happen which kind of triggers all of those negative assumptions, and then they process the situations in some particular way. So, in the course of therapy, we might kind of get to those bits later in therapy, but we start by getting people to recognize what's happening in the moment, in the here and now, and move from there, right? So getting to challenge our thoughts is a core part of CBT. We sometimes use like what we call a thought record, or this is kind of a version of it that we call the 3Cs. So catch it, check it, and change it. So catch those distressing thoughts, you're checking it out to say, what does the evidence suggest, and how might we change it to a slightly more helpful or adaptive thought itself, right? And so this is the sort of really the technical bit of CBT, but so much of the art of it is like really thinking about how do we do this in a way that the person feels connected to us and it doesn't feel like homework that we're just doing. And the same way, we also might do what we call behavioral experiments, which are very, very powerful. So for instance, I have done this with different people where we say, what happens if the person says, I think someone is following me? Say, okay, how do you know they're following you? Well, when I go outside, I see them waiting, and I go down the road, I see that they're still walking down the same way. We say, great. If you turned suddenly to the other side of the road and walked back, what do you think that person would do? They might say, I think they would cross the road at the same time and then walk backwards if I do that as well. Say, okay, let's test it out. And we'll test it out a bunch of times, right? So we're going to be like little scientists, and we'll see how many times, if someone is walking the same way, there's a shop on the other side of the road, it makes sense, they might cross there. But if we went there and just moved back, how many times do we think that would happen? The person says, I think that would happen 10 out of 10 times. Great, we test it out over and over and over again and see how many times out of 10 it happened, and what does that mean for our beliefs. So it's a chance to kind of do that in the real world to sort of change our beliefs itself. And hopefully, that's a chance to then go back and challenge their paranoia as well. Now, CBT obviously requires us to talk a lot about the person's beliefs, and so my colleague Stefan Moritz, who's based at the University of Hamburg, and Todd Woodward, who's based at UBC, where I am, had developed MCT, which was kind of a knowledge translation exercise. It came out of discussions that Professor Moritz gave to different family groups, where they said, oh my gosh, we were talking about that jumping to conclusions bias and the Bade bias that we saw, and they said, oh yeah, I can see how that plays out in real life. And he said, why don't we try to have a group with our patients where we show them how this plays out in daily life and see if that might help them with their beliefs as well. And so from that, he developed this, particularly focusing on the jumping to conclusions and the bias against disconfirmatory evidence. And now, there are 10 sessions in the treatment as it's run, and it's actually been translated into many, like 30 different languages, including Tamil, including Hindi, and has been quite well validated. And the idea is it's much more experiential. So we don't get people to talk about their own beliefs, but what we're trying to do is to see how does this play out. So this is one of the exercises from one of the modules where you're told, okay, I'm going to show you a picture, and I'm going to show you the picture in parts, and I want you to tell me as soon as you're sure what you think this is a picture of. And in a small group, people would discuss, and then it's kind of a challenge to see who gets there first, but also who doesn't get it wrong. So you see that. What do you think that is? It could be a smiley face, a bowl, a boat, a rocking chair, a sled, an elephant's head. We look at those two, we say, oh, maybe those are tusks. That could be an elephant's head. Maybe that's a sled. Oh, okay, now it's looking to be a rocking chair. So obviously, if you guessed too early and you said, I know what it is, you get it wrong. If you wait too long, someone else got to it before you. So there's this happy medium between waiting too long and jumping to a conclusion too early. So the nice thing about playing a game like this and people discussing it is that then we start to normalize those experiences. We get people to say, look, all of us do this. But there are obviously times where it's helpful and times where it's unhelpful. This is another exercise from that same module. You'll see a picture. Look at that picture. Tell me what you see. Do you see an old man and an old woman? Yeah? Do you see a vase? And what's interesting is that our brain kind of flips back and forth between those two. If you see the vase, you can't see the old man and the old woman. And then if you see those, you don't quite see the vase because our brain focuses on it in different ways. And then if you zoom in even closer, you see it's like one of these cute little art pictures with a man playing a guitar and a man sitting there and someone coming out of their house in a tunnel. So our takeaway from it is more that, making a quick decision isn't always an incorrect decision. It's just sometimes you don't see the whole story, right? If you just think you've seen one thing, you're not staying open and curious to all the different things that could be going on. And then we talk about how does that apply to psychosis, why is that important, and really kind of getting people to reflect on that idea that, look, sometimes you want to make a quick decision. If you're standing in a lunch line to pick up something, you can't be like, which one? All the people behind you get out of the way. Whereas other times, if you think your neighbor's trying to kill you, you don't want to just jump to that conclusion. You want to slow down. You want to look at other explanations. You want to see what's a boring explanation for what's going on and maybe start to work on that. And then the homework exercise for people is really to think about when am I jumping to conclusions here? Is there a different explanation? And they start to bring those skills into their daily life. So, in addition, there are now a number of really fascinating approaches to treatment. There's a whole wave of trauma-informed interventions, so people doing trauma-focused treatments for PTSD, which have been shown to improve outcomes in psychosis. I'll show you one which I think is just really cool, that we're just doing a study on, which is called avatar therapy. And in it, essentially, if the person hears a voice and they have a picture in their head of this is what the voice looks like and this is what the voice sounds like, we have them working to create a picture of that voice on the computer screen, and then they put on a VR headset, and then the therapist says what the voice was saying to them, and then they have to learn to stand up to the voice. And then over time, they start to see, like, maybe I can stand up to the voice. Maybe what the voice says isn't really true. And the therapist can kind of, as the voice, can back down and teach them how to respond to it. And this was some great work done. The person up there, his name is Tom Ward. He's a psychologist in the UK, and they did a big study showing that for a group of people who had all been, received multiple treatments for hallucinations but still had persistent voices, they had huge effects in reducing their voices, and about 20% of them, their voices completely disappeared after doing this. So we find this a really kind of intriguing proposition that we are looking at for ourselves as well. So hopefully I've shown you that there are these interventions which look at treatments for delusions, for hallucinations, for negative symptoms. We're really kind of focused on getting people to have more rewarding experiences in their life, and to really kind of bolster those reward circuitry that we were talking about, which has really been kind of dampened down by loss and trauma that they may have dealt with as well. And then for the cognitive concerns, we have a whole other group of therapies that we call cognitive remediation. And cognitive remediation aims at improving, what we call basic cognition in not just the schizophrenia spectrum disorders, but other mental health conditions as well. So why is it important? First of all, is, it's important to know that, as I mentioned, problems with memory, attention, planning, language, and so on are actually quite a reliable finding in schizophrenia, and they may in fact be a core feature of the illness. And we know that actually when we look at factors which are associated with daily life functioning, the level or severity of the person's delusions is not as good of a predictor of daily life functioning as cognitive challenges. And in fact, we know that the magnitude of those cognitive challenges is a predictor of daily life functioning in employment, independent living, and quality of life itself. So we think about these, as we call it, the 5 Ps, that these cognitive challenges are pervasive, they are persistent across the course of the illness, they tend to present early, they progress early. There's typically within the first few years of the illness, there's a 2-step effect on cognition, and they predict functional disability. So when we look at the magnitude of it, and this may be for those of you who have done some stats, that 0 line up top is the mean of the population on a bunch of test scores. And these are tests of attention, abstraction, verbal memory, etc., etc. We find that when we look at people with first episode schizophrenia, as well as people more further on in their illness, you see the pattern of deficits is very, very similar, but it's a little bit more pronounced for people who've been unwell for more than 5 years. And there are the significant weaknesses we see are in domains like attention, abstract thinking, flexibility, so kind of aspects of what we call executive functioning, processing speed, and the biggest one is in verbal memory. So these deficits, this is some fancy stats by my colleague Chris Bowie, impact things like community functioning and work independent of negative symptoms and positive symptoms and depression and so forth. So addressing and trying to find ways to improve these domains of cognition is going to be really important to help people get back to work, living independently, and so on. And so for that, it'll also help to hopefully reconceptualize how people see the difficulties that a person is having. So, if we say, this person misses their appointments frequently, they don't refuse treatment, they say it's not going to work, they blame other people, they don't have insight, they have unrealistic goals, they're disruptive, we can also think of those as then being related to the cognitive challenges themselves, right? Like they might be missing appointments because of their memory difficulties, or they might really struggle with considering multiple outcomes, or they may have difficulties with problem solving or perspective taking or impulsivity, and that's what's causing some of these difficulties. So we can also understand some of the daily life challenges that the person is having as being related to those cognitive challenges itself. So cognitive remediation is, again, a structured clinical intervention to help to improve those domains of neurocognition. And when we think about the components, a really key part is, a few years ago there was a whole wave of these computer games that came out, which were thought to help with improving memory. And what they found is if you do the computer game, you get better at the computer game, but you don't get better at real life stuff. So actually effective cognitive remediation does require, the person to have a sense of, okay, what are we working on? They work with the therapist, they might do these computer exercises, and typically these are computer games that will increase in difficulty. So as you get to one level of difficulty, it kind of gets harder, then you do something more challenging. But really what we are trying to get people to do is to also, while they're doing it, to develop effective problem solving strategies. So think like, what am I struggling with here? How can I use strategies to get better at this? And then take that and translate that into their daily life. how do I bring these strategies that help me with the computer game to my real life activity as well, and do things like, embracing taking on cognitively challenging tasks also. So the version of cognitive remediation that we use was developed by our colleague in Canada at Queen's University, and it's called action-based cognitive remediation. And the action-based part is that in addition to those computer exercises, they do transfer tasks. So I'll show you very, very quickly an example of a computer task and an example of a transfer task. And for homework, really, we're trying to get them to bring those into their daily life towards the goals that they're working on with the therapist. So ABCR actually has 4 modules which focus on attention, memory, executive functioning, and what's called social cognition, or like social skills. And each module has 4 sessions, and typically they last for a couple of hours. So this is an example of a computer task, which is quite a well-known task, which is called the Towers of Hanoi or the Towers of London. And what you're told is, I want you to move these rings one at a time to match that picture on the top right there in the fewest number of moves. And you can't put the big ring on top of a smaller ring. So you can't put that blue ring on top of the purple ring. So you could just start to move things around and do it, but there's probably a fast, effective way to do that. So what we're trying to get people then to recognize once you start practicing the task is, okay, let me break this problem down to a series of small problems. So the first problem is, how do I move that blue ring over to that right-hand side peg, right? So that becomes a little bit easier. I might say, okay, then I can break that down even further. So in order to do that, I have to move those 2 over to the right-hand side, or to the left-hand side. So now I have an even smaller problem, which then becomes easier to do. So then I go 1, 2, 3. So the sort of takeaway from this is less about moving rings, because we're never really going to do that in real life, but that I can take a big problem, I can break it down to a series of smaller problems, and then I can start to tackle those one at a time, and I'm going to bring that skill and that strategy to real life activities. So the version of the real life activity that we do with our clients is, you're told you want to have a dinner party, you're having some friends come over, but then one of them says, oh, I want to bring 2 more friends, and then that friend can't eat dairy, so you've brought all your ingredients, so you have to look through all the ingredients that you have again, and all the recipes, because most of the people that we work with don't cook a whole heck of a lot, so then they look through these simple recipes to see, what could I make, what could I change, what do I have in my fridge and my pantry, and then based on that, kind of updating it. So thinking about like, okay, I need to make something as a main course, maybe I want to make a dessert course, maybe I need to look through these. So what would be the series of problems that we might do? So that, and then in between sessions, they're going to go away and work on the skill that they wanted to do in life, like they're trying to find a job, or they're trying to find some volunteering, or they're learning how to take the bus or go to the shops by themselves, and think about ways to bring those strategies to the daily life as well, and to practice those computer games, which may help with improving attention, improving memory, etc., etc. So I haven't been showing you the outcomes on these trials, but these are all very well-established interventions now. So we've done a bunch of clinical trials as well as what are called meta-analyses. So this is an analysis of all the trials which have been done on that, and then we can combine the effects together to see, is it still effective? And we find that we can show that these are all very effective interventions. So really, when we are thinking about putting things together, depending on what level we are thinking about the symptom or the illness itself, if we're thinking about it at the level of the brain and the neurotransmitters, that's where the medications will have an effect. If we're thinking about it in terms of the functional brain networks that are associated with memory and attention, that's where cognitive remediation could play a role. When we're thinking about it as the thinking patterns themselves, that's where interventions like CBT and MCT can have a role. When we're thinking about the social connections, that's where addressing the trauma and improving social skills will have the role. And so, as we can integrate all of these, each of these is going to be a little bit helpful, and effectively integrating all of these together will be the key part of the recovery process itself, right? Because recovery really is going to involve at the first stage, bringing people back to the level of being less distressed by their symptoms, right? So hopefully addressing the symptoms and their underlying causes. But then the second part is hopefully helping to create a richer and more meaningful life for themselves, right? So we might prevent the relapse through integrating the biological and the psychological treatments, right? Doing the medication adherence, hopefully the therapy which can help with the symptoms and the trauma and the self-esteem, CR to improve cognition. But then we are also going to be thinking about ways to like improve community functioning and creating a sense to create a sense of family, a greater sense of like their own place and purpose in the world, a greater sense of community and connection to other people, because I think those are the parts which are going to be really the creating of a meaningful life beyond of just not being troubled by the hallucinations as much, right? So I think that's the sort of larger picture of recovery that we hope we can all get to. So lots of people to thank. I do this work with my lab, which is run with Professor Todd Woodward. The MCT work has been developed by Stefan Moritz. And then, of course, here, Dr. Vandana, Dr. Ravikant, who is responsible for me coming here, the people who've helped, like Purnima and Aishwarya, to put this talk together. Thank you all for your attention. So there's a number of questions that we had, which I will try to answer somewhat satisfactorily. So one was, how can cultural nuances and individual belief systems be integrated into multimodal treatment approaches to ensure holistic recovery for psychosis, particularly in diverse populations? And I think a part of this really is, it's going to be at two levels. I think one of the big discussions that we've been having is, it's important to have a menu of options that people can engage with, and then hopefully they can pick and choose the ones which might be the most relevant to them. Hopefully the clinicians can work with them to help identify which interventions would be most meaningful to them. But then in the course of the intervention itself, I think when people learn CBT, it can be very easy to think of it as like paint by numbers therapy. And that's really therapy done badly, where you bring someone in, you say, look, your thoughts are not accurate because of your anxiety, and here's a better thought. That's really bad therapy. So the formulation that we talked about, where we're really trying to understand the person's own unique experience in the context of their life experiences and their own beliefs about themselves and the world, and how those play out in the symptoms that they're experiencing, and addressing those in the individualized fashion, ultimately is kind of what good therapy is all about. So I think that having a range of interventions to address the kinds of difficulties that the person is struggling with, as well as having individual therapy, which really is formulation driven, the combination of those two, I think, is going to be critical for the personalized treatment. The other question was, given the evolving landscape of digital therapeutics, how can AI-driven tools and virtual reality technologies complement traditional therapies to improve cognitive and functional outcomes? I think there's a lot of room for it. There are many people who are developing both traditional therapy apps as well as now more AI-related apps. So there are, I didn't have time to get into this, but even my colleague, Professor Moritz, has an app that goes along with MCT, where it can prompt you to ask the question, am I jumping to conclusions? Is there any other explanation? And we can write down some of the things which we may have come up with in session together. I know when I see someone with sunglasses on, I think that they are following me, but that's not true. It could just be a sunny day, and we have those in the apps which can be provided to them. And then as AI, I think, comes along, you can start to have the AI kind of support that back and forth conversation to be the sort of therapist outside of therapy as well, reinforcing some of that also. What tools can be used to measure long-term stability of functional improvements? How can these be standardized globally? I'm gonna just say, like, there's obviously the tools will depend on the specifics of the question, and standardization is a delightful, nerdy, quantitative approach, which requires excellent normative data, validity, and concurrent validity. That is boring to most of you that will be listening, so I'm going to skip the rest of that. But I'm happy to talk about it at length. Yeah.
Sorry to interrupt. We have more questions.
Okay.
You can just pick and choose.
Okay. How do you help individuals who have schizophrenia start treatment when they don't have insight into their disorder and are paranoid? I think this is a really important question when we're doing therapy. And I think it boils down to two things. One, for all of us, we have within us the battle between wanting to connect with people and wanting to avoid being hurt. And so the first part of good therapy involves developing a therapeutic alliance with the person where they start to see you as someone who can understand their experiences and isn't going to hurt them. And I think if you have that, then that's a great starting point to then be able to then talk about the really difficult things. So we spend a lot of time in therapy just listening, getting to know the other person, using those person-centered therapy skills to make the person feel understood, to feel validated. And then when we are thinking about therapeutic goals, ultimately we need to find common goals that we can work towards. And I think that's a key part of therapy. So if my clinical diagnosis is this person has schizophrenia with paranoid delusions and auditory hallucinations, that's just a shorthand that I write down, which might mean something to me, but it means many different, usually negative things to the person that's listening. So what we are really thinking about for that person is, I want to not feel scared to leave my house, and I want to not feel bad about myself when the voices call me names. Those are goals we can agree to work on together, right? I want to feel safe. I want to have a wife. I want to have a job. These are all goals we can work on together. So ultimately we find those goals and then we think about what are the ways in which the symptoms are getting in the way of those goals and hopefully kind of work on those together. How can therapies account for the intersectionality of mental health conditions like psychosis with co-occurring disorders like substance use or PTSD? And what strategies can social workers use to advocate for integrated care models? I think, again, the people who are much better suited to address those issues would be people like Dr. Vanna, who's done the work of creating the advocacy and pathways to integrated care models. I think that ultimately the government, it sounds like, recognizes the role of those, but the nice thing is, as we get to know our individual clients, we're finding that same balance between having a big menu of treatment approaches which are available to them, but in our work with them individually, if we recognize what are the factors which are driving the problematic behaviors, whether that is the psychosis or the substance use, and are there ways to address those underlying issues, sometimes that can be helpful. That's not to say that everyone that has, a substance use problem is necessarily escaping from a problem, but many of them might be, and kind of addressing some of those underlying issues can help with dealing with those issues as well. And ultimately, like we said, all of our interventions will need to be specifically culturally adapted to use in the context that we are in, because the goals that we might each be working on, the language that we might use, the role of family, the role of religion, the role of our immediate communities will all vary. Not just kind of from the Western context to here, but also within each community that we're working in. So I think that's where each of you that works in a community will hopefully become an expert on the role of the culture there and how we may adapt our interventions to use with those cultures. Interestingly, there were multiple questions around culture. what is the role that social workers play in bridging the gap between clinical interventions and the social determinants of health, like housing instability and unemployment and stigma, to sustain functional improvements? I think this can be a really important part. I think that particularly in the world that we work in now, it is helpful for each of us to have a little bit of knowledge about the tools of our other allied disciplines as well. So I think as social workers, it's really helpful for you to have some of the training in things like person-centered therapy and motivational interviewing, and an understanding of how does CBT work. So even if you aren't getting into sitting down and doing long therapeutic sessions, as you address those social determinants of health, like helping people with being able to kind of get their funding sorted out, or being able to get the housing sorted out, you would also be able to help work with them and their families to reduce stigma. You might be able to work with them to improve their motivation to engage in more adaptive health practices, or to connect with a psychologist or a therapist, because there is so much stigma that's attached to those as well. So the work that you do in bridging those communities together and addressing some of those basic needs is ultimately going to be really crucial to the long-term recovery component as well.
We also thought we could hold open to the audience so that they can be direct interaction as well.
Absolutely. That's, I think, way better than me reading the questions out also. Yeah.
Thank you.
Sure.
I give you some time for drinking. So thank you very much. The floor is now open for questions and direct interaction. So if you all have questions, he would be very happy to answer all of them.
Sir, is it possible for a person who's not having any hallucination or delusion when they are out of their home, just they're having in their home, but they are not having it in when they are in their workplace or out of the home?
Yes, it's so. I think it. I wouldn't say. I think it's common to have hallucinations in some contexts more so than other ones, because the triggers for hallucinations can be different. And I think again, one of the pieces that we're trying to understand in therapy is what are those triggers. So, for instance, for some people, they hear voices when they're by themselves, or some people hear voices because our expectations of what will happen drives, some of the factors like voices, right? So people who say, when I'm home by myself, is when, the neighbor is putting bad thoughts into my head. Now, because I think that that's the case, that tends to happen more in that context as well. Oftentimes, there are some things which people find a little bit more stressful and aversive, and in those situations, the voices tend to be a little bit worse. But the delusions, oftentimes, if the person thinks that the bad thing's happening at home, they wouldn't think it's happening outside, so that's good. But lots of times those fears generalize as they stay stressed. So if the person thinks that their neighbor is trying to poison them, then they might feel safe when they go out to work. It's not to say that they don't have the delusion at work. If you ask them at work, they'd still say their neighbor's trying to poison them. They're just not scared about their neighbor at that point in time, right? But many times people will think about like the geographical cure. They'll say, okay, I'll move to a different house, then it'll go away. But what they find is that they go to the different house, at first you feel calm, but all the underlying factors which is driving it then still come back, right? If they're hearing voices, they might be prone to hearing it as well. So then it starts to happen in the new place. Typically, in my experience, when people have done that, within like a month or two afterwards, it starts to happen again. And then they say, that same neighbor moved, or he told my neighbor to start to do this to me as well. And so the cycle repeats itself. So we're really trying to get at the underlying factors.
Some of the things you said about the ethnic density and all of it resonate a lot, like despite in what I've seen with people who have experienced this. So there's the ethnic diversity, and you've talked about like the histories of trauma that people have. I've always wondered what this focus of like all academia and medical intervention for it to be individualistic, and then not just individualistic, but also to then make it to center it around all of how schizophrenia has ever been defined or taught to us, which you covered, has always been symptom focused and not distress focused, right? Does this pathologization not again So for me, it's just been very hard to contend with this approach to an individual and their distress, given the histories, given the background, given the potential source of it. Yeah.
So, yeah, I guess if I'm understanding correctly, you're saying there is a risk, I think, that, like, so for instance, when there was the, like in the 90s, there were the first kind of genes which were thought to be associated with psychosis came along, and they showed that, you know, some genetic alleles kind of increased your risk. But those kind of gene markers and the amount of risk that they confer is really, really marginal, right? Like, there is a particular genotype which increases your risk, population risk, from 1% to 2.5%. Statistically, that's a huge increase, but in functional terms, it's not very much. But I think one of the big things was, the hope was if we see it as a brain illness, it would somehow reduce the stigma around it by saying, look, it's an illness like any other illness. But the risk of it was that it increased the sense of hopelessness that some people had about it. It's like, oh, the brain is kind of flawed, and then it just sort of led to another wave of stigma, right? And I think that ultimately, if we as clinicians focus on people's distress, I think what you're saying there is we're shifting away from the specifics of the symptoms. We're shifting away from like pathologizing them and thinking about these as like understandable consequences of difficult life experiences and so forth. But I think that those two forces are always going to be in battle with each other. The people who want to use kind of a shorthand for anyone that's different from us and struggles with things which we don't struggle with, versus the people who might want to have a more compassionate, inclusive approach and see each person's struggle as being understandable in the context of their life experiences. So I think besides the work that we do, a big part of what our challenge will be would also be to like educate more people and to bring them into a more compassionate, less stigmatizing perspective of it. So that'll fall back to all of us. Oh, of the different interventions, you know, honestly, one of the limitations that we've seen with therapies is that in the context of clinical trials, almost all the interventions, when they are done by good therapists, have a similar effect size. So they all kind of get to an effect size of, you know, statistically like what we call 0.4, but they don't. We're not able to kind of get huge ones. So the Avatar stuff actually had a huge effect in that first study, but there've only been a handful of studies that have done it. As we kind of do more, it might kind of level out. But I think the bigger thing then becomes, how do we identify the people for whom, you know, we can tailor the interventions? We might say this person will benefit from this person will benefit from this other one. And those are, I think, that the stage that we are right now. So all of them have been roughly as effective as the other. So that means all of them really work well for some people, kind of for some other people, and not at all for some. We now need to figure out how do we really identify who are the people that it will be the most helpful for. So I have not been involved with the work here, but I know that there have been some trials. There have been trials at NIMHANS. I know that there have been some work that's been done at SCARF. And there are some like kind of cultural adaptation studies that have been done both in India and Pakistan and Bangladesh as well. So, yeah. She's taking the mic back, but you can yell your question out while she's doing that.
All right. Sorry, my question is more along the lines of, well, it's more like, I guess, it makes sense at the end, but in the global south, right, there's a real issue with the accessibility of care, especially in the context of schizophrenia. In which sense, like, I agree with you on the multimodal, approach to care, but in those kind of situations, do you think it's appropriate, or do you think it's beneficiary to focus on one particular model? Let's say that in that case, just the medical model, let's say, in that sense, just in terms of ease of accessibility. And do you think that could have an impact into the long-term mode of care, let's say, when accessibility is no longer an issue?
Yeah, so I think this medication is important for two reasons. I think one, there is a whole lot of data that shows that it is quite helpful, and people who aren't on medication tend to relapse. But I think the second reason why it ends up being quite widely used is because if someone doesn't want treatment, they can still take a tablet or be made to take a tablet, right? So, like, the sort of bad joke about psychologists is like, how many psychologists does it take to change a light bulb? Just one, but the light bulb's got to want to change, right? So you can't force therapy upon someone that doesn't want to do it. You can't force change upon people. So a lot of the other work then is about kind of developing readiness for change or helping people kind of connect to a different sense of themselves. And I think that there are probably going to be a vast different array of interventions that we can look at around things like, how do we get people to have a kind of like, in the context of like intersectional identities, how do you get people to have an identity which is less about the symptoms that they're dealing with and more about other aspects of their life and how they might see themselves, which may take an entirely non-therapeutic, milieu-based approach and so on. And I think those would be the types of things which could then also, in that context, if someone says, therapy will help me do that, then yes, absolutely. A job might help me do that, absolutely, right? So I think that there will be a whole collection of different interventions which can be tailored in different ways in a context here versus some other place.
The question is about the application of avatar therapy. Especially when you look at avatar therapy, it creates a very realistic image about the visuals. Most of the time it could be disturbing. So when you apply with a client, does it also have an adverse effect of being a trigger? So what was your experience?
Yeah, so it's probably going to be a selective group of people who we tell them exactly what we're going to do. We give them the control over it, and so some people, when like I've spoken to some of my clients saying, hey, there's this therapy you can do where we'll develop an avatar of the voice and you can talk back to the voice, and they just say, no way, man, I'm not doing that. You're like, okay, so then we've ruled those out. There are people who come into the therapy, sometimes when they see it for the first time, we also try to have them put on the VR goggles and they see it, it can be quite distressing to them. So before they do that, we spend a lot of time kind of helping them to learn how to do the deep breathing, to ground themselves. And then they have the option to make it smaller and disappear into the background, or they can just press a button and they actually leave the room with the avatar and they're in a sort of peaceful beach scene where they can practice doing the sort of breathing and relaxation, and then they can go back to it. But really what we're helping people to see is kind of a little bit, it's a bit like watching a scary movie versus being in real life in that situation, right? So if I'm watching a movie about a psychopathic murderer, it's scary, but it's not as scary as if I thought there was a real psychopathic murderer trying to kill me. So I think we try to have a bit of that balance between the two, where it is scary for the person, but they're able to recognize this is an avatar of your voice. It's not the voice. You are in control all the time. But as you learn to stand up to the voice, we actually record the interactions that they have with the avatar and give it to them to listen to. And we find that that helps them then stand up to the voice in real life outside of the sessions as well. So that is a hope that we would see. The big trial that was done, that was actually something that they found to be quite effective. And then ultimately, for instance, let's say the voice is repeating the traumas that they heard when they were children. The therapist can then say the things as the voice that the voice might never actually say to the person. So the therapist can say to the client, as the voice, I'm really sorry this bad thing happened to you. You're a good person. You didn't deserve this to happen. But they hear it as the voice, which can be really powerful and impactful to them, because they may never have that happen in real life for them. And I think that is another huge part of the change process.
Sir, I've seen a lot of therapists correlating mandala therapy and schizophrenia. Does it actually have an effect, or is it just a myth? Mandala therapy.
I don't know what mandala therapy is, unfortunately, so I
Okay. So it's basically, in Jungian terms, it's kind of self-healing, but what you actually do is draw patterns in symmetrical way and you keep doing it.
you know, because I can't, I don't know enough about it to say, but you know, one of the nice things about like the idea of science, and I hope that all of us will kind of come around to it, it's not to say that this is right and this is wrong, but rather that we have a set of tools to evaluate an outcome, right? So you could do a very simple, what would be called a randomized control trial with it, right? So if one group of people is taught how to draw the mandalas and they will do that, and that is their intervention, and the other group of people will copy pictures of horses, and you can look at what, after 6 weeks of doing this, are there any changes in symptoms? If both groups have changed the same amount, then it wasn't the therapy, but just the act of drawing. If one group has changed much more, then there might be something specific to it. So we can test out all of these ideas in a very simple, clear way, and that is my hope, like that we just kind of, if there's an interesting idea, we should test it out using the same scientific method, right? And so.
Good evening, sir. As you have mentioned cannabis in the psychosis thing, I just want to ask two questions. One is that how does the potency of cannabis influence the risk of developing psychosis? Second one is that is there any evidence to suggest that cannabis-induced psychosis differs from other type of psychosis in terms of symptoms or outcomes?
So there is, yes, there is a link, I think. So increasing, particularly, like there are obviously a number of psychoactive compounds in cannabis. The two most well-studied are what's called THC, and CBD is the other one. And we know that actually increasing ratios of THC potency is associated with increased risk of psychosis. And interestingly, kind of just low THC CBD strains may not be as risk related. So that's good. The second one is, you know, people talk about substance-induced psychosis, and technically, when we're thinking about a substance-induced psychosis, we can think about it as like the acute effect of the substance itself. So For someone who smokes weed a lot, they might have periods where they become paranoid. And if they became really paranoid to the point where it warranted hospitalization, technically that would be a substance-induced psychosis. But for that to meet that definition, once the THC washes out of their system, and their paranoia should subside. If it persists, then what we can say is that whatever combination of factors is tipping their brain more towards developing a, in quotes, true psychosis itself, right? And so I think within that context, yes, for people who've just had the substance-induced psychosis, they do have better trajectories because they stop smoking weed and they feel better, and that's good. But there are people for whom, if they had a vulnerability to it and it tipped over into the psychosis, some of them might continue to have a similarly kind of relapsing pattern, even if they're not using at that point. There's some really fascinating data that they did from a longitudinal study in New Zealand on a small island called Dunedin, and they tracked this group of kids from the time of birth to they're now in their 40s, I think. And they found that the people who, again, the substance use and stressors also interact. So the kids who were bullied at school or weren't doing well and had school difficulties, they also tended to smoke more. And so that substance use pattern, especially in the early teens, was associated with a higher risk of developing psychosis. But those school difficulties and the problems that they had may have also been indicative of neurodevelopmental issues, or may have been indicative of other traumas that they were dealing with, which they were coping with by using substances, right? So all of those, I think, feed into each other and can kind of lead to negative outcomes. But the most there are only a few preventative steps that we can take. One is avoiding cannabis, especially in kind of the early mid-teen years, avoiding those stimulant drugs like cocaine, methamphetamine, etc. Kind of there's a lifetime risk for all of that. And then all of the early prevention programs that we have around reducing bullying, providing support for trauma, I think those will be the things which will ultimately be really helpful.
Hi, sir. This question is less about the therapeutic approaches and more about the clinical treatment that one would give to a psychotic patient. Suppose there is someone who has come into the hospital with severe psychosis. Does the practitioner require explicit permission from the patient to be treated? I was just wondering how it works in the psychiatric context. So could you shed some light on that?
I think that is completely dependent on jurisdictions, right? So I think the rules in Tamil Nadu may be different than even other states in the country. I can tell you in the Canadian context, the rules in BC are different than the rules in Ontario. So if you go to a hospital in Toronto, if you are brought in under what's called the Mental Health Act, you are brought into hospital for treatment, but they can't mandate you to take the tablet or the injection unless they think you are at risk of harm right then. Whereas in BC, the idea is that you are at an ongoing risk of harm to yourself, and delaying treatment is worsening that harm, so that justifies treatment. So in Vancouver, if you are brought into hospital by the police, or they say, yes, you need to be certified under the Mental Health Act, they can initiate treatment. So I think that is very much a jurisdictional question here. And I'm honestly not sure of what do you know? Yeah. So you mandate treatment. Yeah. So then here, if you are brought in, then you can be treated against your will, technically, and they can appeal. Yeah. So it's the same process. So you can appeal the kind of involuntary treatment, as it's referred to, and that it will be reviewed by a psychiatrist. And if they say, no, I think this is correct, you do need the treatment, then you'll be kept under it. And for us, and I imagine it's a similar thing here, there is your first certificate for treatment is 24 to 48 hours, then it becomes up to a week, then it becomes 3 months. And so you can appeal for each new certificate renewal. So.
Thank you, sir.
So
we have room for last 2 questions. Anyone wants to have a go at it?
No pressure.
So we talked a lot. This is related more to how you talked about a little bit about CBT being done bad. Telling your client that, oh, this thought is irrational without empathy in that statement is basically what I got from it. And that got me thinking, so where do I learn to become that empathetic? And that got me into, like, you mentioned a lot of treatment options and like psychosocial treatment modules here, like CBT for psychosis and cognitive remediation. So where do we go and learn all of this?
There are obviously there is an Indian CBT association, and I think they have courses. I know that there are going to be courses through programs. CBT is sort of the juggernaut of treatment because it is the most empirically validated, right? So there are the most studies on that. There are also a number of online training options which are available as well. So people can do the online ones, but those are probably good introductions to CBT. Ultimately, the components for a good training program will involve learning the therapy or learning the theory, then practicing it in session, having supervision, getting feedback to say, look, here's what you did right, here's what you did wrong, and then being able to kind of adapt that and update it. So when I was training, I was lucky to have a supervisor who would watch what I did, and it's really kind of a bit anxiety provoking and embarrassing to watch yourself on videotape looking like an idiot and then having to say, well, she'll pause it and say, could you have done something different there? Yes, I could have. And then you practice all the different things you could have said, but it's really helpful because then you recognize how you could do it better. And I think that might be the sort of level to really get skilled. But so where you would do it, I couldn't tell you how you would do it. I could tell you this is probably the way to do it right. Yeah.
Yeah, we have room for one last question.
When you were talking about schizophrenia and when you defined what it means to have schizophrenia, you said that one of the major symptoms is them assigning meaning to really small things like their sight. Things that most people do not notice, they form a narrative out of it. And I was thinking, couldn't that feature in and of itself be quite useful in other contexts? There are seers, there are prophets that there are prophets that kind of make narratives, meta-narratives out of a lot of insignificant events that most people would not assign that much meaning to.
Absolutely.
But eventually it turns into this huge story that is quite useful for most people. Like it gives them a self. So I wonder how it ends up into a pathology instead of it being a boon to society in sense.
Absolutely, and I think that that's a really good point because. If we think about this evolutionarily, only a small proportion of people who have schizophrenia have children. But the proportion of the population with schizophrenia has stayed roughly stable at about 1%. So that then means that whatever risk genes you have to develop schizophrenia are obviously in evolutionary terms conveying some sort of advantage in other contexts, right? So there are interesting studies that show that some of the genes which are associated with schizophrenia and bipolar disorder are actually associated with creativity, with making interesting connections between different things, which would allow you not just to be an artist, a poet, a musician, but also to be a really creative engineer, to be a really kind of creative thinker, to be a philosopher. And those things may still kind of continue to have that advantage. If we also then think at a lower level, kind of, so, it's not that you have schizophrenia or you don't have schizophrenia. So we really think about this as a continuum. And so you can have someone who has none of these experiences, people who have a little bit of experiences, people who are having more of those, and then kind of quite extreme ones. And then at a separate process from that, we can think about the negative impact that those experiences are having or the distress that those experiences are causing. So we will have people, you might have a kooky friend who, likes talking to, invisible angels and, thinks that things are a good omen or a bad omen, and that happens every day. But they're just quirky, they're living their lives. That technically could be the subclinical presentation of schizophrenia. And it is sort of like the risk level is called schizotypy. So that could convey an elevated risk of developing it, but they may not. So, but some of that could also be associated with just interesting life choices, being creative. Some of them might hear voices, and those voices, because they aren't struggling with the trauma or they have kind of made sense of it in a different way, they bring it out in a more profound and philosophical way, and they might be the prophets and seers that we see, absolutely. So it's not just the presence or the absence of the voices or the presence or absence of odd and unusual beliefs, but the fact that it causes them distress, it prevents them from living a meaningful life, and it's having a negative impact on their families around, which is what we're really trying to get at, right? So I will say to people as well, look, my job isn't to change your belief, right? I would hate it if someone came up to me and said, hey, you're wrong about your beliefs, right? But it's to say, this is really getting in the way of your happiness. What can we do to make your life richer, more meaningful, connect you to the goals that you want to have? That's ultimately what we'll work on.
Thank you very much, and it's been a riveting session, and now I will invite Professor Ramesh to give the vote of thanks.
So I was about to say thanks for coming all the way from Canada, but Dr. Lakshmi already said that you are on vacation in Chennai. But anyway, we know that in between vacation, preparing for this kind of lecture, and especially when we said that our audience is of different background, psychology, family counseling, and then social work, and then he said that I will make it as simple as possible, which I think I witnessed also, because I was a student 25 years ago sitting here, but I can see you made it so simple, all the content. So thank you so much for doing this for us, and the entire auditorium is full. Very rarely lectures have a full auditorium. I think yours is one of it. So this will stand as a history. So thanks to Vijaya ma'am for interpreting throughout nearly 2 hours. Thank you so much, Vijaya ma'am, for this. All the events madam is doing for us, we are very grateful to her. And then thanks to Dr. Kalyani ma'am, because when we reached out to her with the background of the speaker and the topic, so she immediately accepted. The one is to introduce all of you, the psychologist who is both academician and practitioner, and from Chennai to Canada. So a lot of that exposure, I'm sure that you want your students to have. Thank you so much for accepting our request and hosting us here. And thanks to MSSW, especially the principal, Dr. Raja Samuel sir, for always encouraging us to have events here. He said that these events empower our students, not just the knowledge level and also exposure, and also have a new perspectives. A good example that he shared is whatever you think differently, why don't you do RCT. I think that's an interesting, suggestion. I'm sure Mandala is going to be done. I hope so. Okay. Thanks to all our audience, because without you this event has no meaning. Thank you for engaging with your presence and also asking all insightful questions, both online, offline, and also written scripts. And our own Baum and Banyan team, for organizing this, especially Ms. Purnima and a lot of other colleagues supported her. I don't want to name everybody. And Dr. LRK ma'am for co-designing this event. But all this started with our own co-founder Dr. Vandana madam, for making sure that this event happens here with the right speaker. She is here. She is also our alumni. Hope some of you or all of you know. You might have seen her photo in Hall of Fame in the hall. If not, go and watch it. And very importantly, this entire event is not possible without the support from Sundaram Fasteners Limited, who always supported this kind of initiatives to promote students, especially in their career advancement, and make sure that they contribute as a best mental health professional, not just in our state, for the country and the global. Thank you so much, SFL. Thank you all. We have a small refreshments. Please accept this. Good day.
Yeah, so on behalf of all of us, and also thank you for participating in this session. Refreshments are further down, which you can access. And I believe this is the close of the session. Thank you so much for attending.